My name is Jeff Lehrman. I'm an advisor to the APMA Coding Committee and MACRA Task Force. Dr. Jim Christina will speak later, as will Dr. Phil Ward. We start with MIPS, this program that none of us like, and in my opinion is not fair and a tremendous burden, and there is zero literature or evidence to suggest that it improves the quality of care that we provide. But it's here. And if you want to be a doctor in the United States in 2018, you have to deal with it. So we have to tackle this. I think it's important to note that this has nothing to do with who the president is, or who the Secretary of Health and Human Services is, or who the CMS administrator is. And a lot of times we hear, well, why couldn't you stop that? And why doesn't APMA fight that? This is where it came from. It came from Congress. It passed with, as you can see, robust bipartisan support. If we want this to go away, these are the people that have to change it. And there are a lot of minds that need to be changed in order for something to change here. So that is a separate effort, which does happen, but our purpose today is to recognize it's here, and as long as it's here, we have to deal with it. And our goal is that 2 hours and 15 minutes from now, you know everything you need to know to make a decision as to, do I want to participate? At what level do I want to participate? And how am I going to participate? How am I going to tackle this? What makes most sense for me, for my practice, for my associates, and that you have all the tools you need to succeed with this program. And absolutely avoid a penalty. And in my opinion, I think you should be shooting for earning a bonus, because it's not that hard to get a bonus. And we're going to show you how. So as an introduction, and I know there are people in the room that already know this, but I hope it doesn't hurt to refresh this content, because there are others in the room that do not know this. So we had the SGR, the Sustainable Growth Rate. And this was this crazy program where we heard we were going to get a 22% cut, and then a 24% cut, and then a 20 whatever percent cut, and it went away. The SGR was repealed. The Sustainable Growth Rate went away, and we never got that crazy cut. The Sustainable Growth Rate was replaced by MACRA. There are multiple components to MACRA. There's all kinds of stuff under MACRA, some of which we don't even care about. But the one that's pertinent to today's discussion is the Quality Payment Program, QPP. And this is an acronym that CMS is using more and more, so this is a good thing to have a familiarity with. The QPP, the Quality Payment Program. So, and I'm going slow and repeating myself, because this is one of the goals we have, is that everybody that attended today gets these acronyms, and you understand them, and you know what you're talking about when you use them, and you use them appropriately, and you know what others are talking about when they use them. So the SGR went away. It was replaced by MACRA. One component of MACRA is the QPP, the Quality Payment Program. Every doctor in the country, and actually many allied health providers, there's nurse practitioners and dietitians, nutritionists, all kinds of people fall under the QPP. We certainly do. So every doctor in the country functions under the QPP, the Quality Payment Program, and there are two paths by which you can participate in the Quality Payment Program. So every doctor in the country can participate in the Quality Payment Program via MIPS, the Merit-Based Incentive Payment System, or an APM, an alternative payment model. It's estimated that about 96% of all doctors in the country will participate in the QPP via MIPS, leaving only about 4% for alternative payment models. And we are pretty sure in 2018 that 100% of podiatrists will function under the QPP via MIPS, Merit-Based Incentive Payment System. So MACRA replaced, one more time, MACRA replaced the SGR. One part of MACRA is the QPP. We, as podiatrists, will function under the QPP via MIPS. So I hope you now agree with me. There is no such thing as macro MIPS. That doesn't exist. It doesn't make any sense. It's just running a bunch of letters together. There's no such thing as MIPS macro, right? So the right way to say it is macra's here. Therefore, we have to participate in the quality payment program, and we as podiatrists are going to do that via MIPS. Alternative payment models probably will eventually replace MIPS. APMA is already working on alternative payment models for podiatrists so that we have a place when that happens, and we have a way to participate. But we're not there yet. 2018, we're in MIPS. That's what we have to worry about. Any questions on that? And I was supposed to say, it was the one thing I was asked to say and I forgot. This is being videoed, and others will probably watch this at some point. If you have a question, you will be recorded, and others will hear your voice, so you need to know that. If you have a question, you can come to the microphone. If you're not comfortable with the microphone, that's cool. I will repeat the question so it goes into the microphone. So please ask questions if you have them. We want them. You have people in the room that know a lot about this stuff. These are the people to ask. So the way MIPS works is we are all going to participate in this program in 2018. And we're going to go through the year, and we're going to do stuff or not do stuff. And we're going to jump through their hoops or not jump through their hoops. And jump through a lot of hoops and click a lot of buttons, or only click some buttons and do some of this nonsense. And based on what we do or we do not do in 2018, all of us are going to accumulate a 2018 MIPS score. A 2018 MIPS score which will be publicly reported. That's an important point. We're going to spend some time focusing on that. So we're going to go through the year. We're going to do some of this, not do some of it, do all of it, not do any of it. And based on what we do or we do not do, we will all get a 2018 MIPS score. That score will be anywhere between 0 to 100. A really bad score is 0. An excellent score is 100. And we mentioned that score will be publicly reported. So we go through the year. Based on what we do or don't do, we get a score, and then at some point in early 2019, every single one of us is going to get a letter in the mail or an email or whatever, probably a letter, that says, "Dear doctor, your 2018 MIPS score was X." And that MIPS score will be publicly reported, and that 2018 MIPS score will impact your 2020 Medicare Part B physician fee schedule. Your 2017 score, which is now over, right? That's done, is going to impact your 2019 Part B physician fee schedule. This year's performance, 2018, will impact your 2020 Part B physician fee schedule. And you can see the degree to which it will impact that. So 2018 score will change the 2020 fee schedule anywhere from -5% to +5% for the most part, with one exception which we'll talk about. So your 2020 fee schedule is going to be adjusted anywhere from -5 to +5% based on what you do in 2018. That is a range, right? It could be -2, it could be neutral at no adjustment, it could be +2, +4, +5, with some exception which we will discuss. And you can see, as the program is currently designed, and there is nothing in place to change that as of this morning, the stakes get higher. So just so we're clear on what we mean by adjusting your fee schedule, because we've had people ask, what does that mean? So hopefully everybody knows you have a publicly available Part B physician fee schedule. It's not a secret. You can look this up. Anybody could look it up. It's a very easy link from the Coding Resource Center if you are a subscriber, and you get your fee schedule. Big Excel document with all the codes, and next to every code is a dollar value. So let's say, for example, on January 1, 2020, you open up your fee schedule, and 11721, we all know that one? 11721 has a value of $50. If you do nothing in this program, in 2018, you take every single number on that list and subtract it by minus 5%. You take 5% off. So for you, for the entire year of 2020, you would get paid $47.50 for every 11721 that you do. If you get plus 5%, you're getting $52.50 for every 11721 that you do. And that's every code on the list. E&Ms, surgery, calluses, ulcer debridement, all of it. The whole fee schedule gets adjusted by that percentage.
DME, is that included as well?
Question was, does it adjust your DME fee schedule also? No. Only Part B services. So it does not impact DME. Doctor.
We're already getting a penalty from the previous program. Do we get a
Right.
clean slate, or is this going to be -4, +4?
Right. Okay, doctor asked, if I'm being penalized this year in 2018 based on not doing 2016 meaningful use and or PQRS, does that carry over in any way, or is it a clean slate? Totally clean slate. The 20 adjustment, somebody's cheering. The 20 adjustment is based on what you do in 18 only. So you could have totally bombed on this in 2017 and be due for a 19 penalty. If you get back on it, because you came today, and you succeed wildly in 2018, you're set for 2020. There is zero carryover. The current year's fee schedule is impacted by what you did 2 years ago only. The most common question we get, number one most common question is, what do I need to do to avoid the penalty? I do not suggest, APMA does not suggest that you just avoid the penalty, but that is your decision. If that's what you want to do, that's absolutely up to you. Last year, in 2017, to avoid a penalty, you needed a MIPS score of only 3. For 2018, the bar has been raised, and in order to avoid a penalty, you need a MIPS score of 15. So for the current year, for 2018, if you want to avoid a penalty, you need a 15. There's more points than last year. It is very easy to get a MIPS score of 15 this year. Super easy. And we're going to show you how. Very easy. Nobody in this room should have a penalty. Super easy to do that. So the bar has been raised from last year to this year. This adjustment that we talk about, -5 to +5, is mostly budget neutral for the most part, meaning however much penalty money there is, that's how much bonus money there is going to be. So it's sort of like being graded on a curve. Some of you have heard me give this example before, but I think it's a really good parallel. I think of it like an organic chemistry exam in undergrad, where you don't need a 100 to get a bonus here, right? If the best score in the class in organic chemistry was 87%, and it was graded on a curve, and 87 was an A+, because that was the best grade in the class. So you don't need a 100, you don't even need a 70 or an 80 to get bonus money here because of this mostly budget neutral deal. So now we come to why I'm saying mostly budget neutral, and with some exception, and that is because if you are deemed to be an exceptional performer by CMS, you are in line to get more than +5%. So you can get more than that +5% if you are an exceptional performer. And for 2018, the bar to be an exceptional performer is 70 MIPS points. So if you go 70 or over, you are now an exceptional performer, and you can get additional bonus money. We don't know how much because there's a $500 million pot of money that is set aside for exceptional performers. So how much extra you get is going to be determined by how many people are exceptional performers, because that 500 million needs to get distributed. And there's other crazy math that determines it, which we can get into if you really want. But the bottom line is, if you go over 70, you are in line to get more than +5%. Nobody knows exactly how much you can get until the year is over. because it depends on how much money you're getting, how many people are getting the extra pot of money. So be careful. If you see a vendor, an EHR vendor that says, we promise you X% bonus if you go with us, they can't say that. There's no way to know. Think about it. If every single person in the country gets a MIPS score of 90, which isn't going to happen, but just to exaggerate it, that percentage is going to look a lot different than if 2 people go over it. So they can't promise you that, and that worries me when I see that. So just be aware of that. Our goal here, this is something we've always said when this started years ago. Our goal is to give you the what, so that you can go to your EHR vendor and ask the how, right? We want our members, we want people that come here on a Saturday morning to be informed and educated so that you know exactly what you need to do, and you're not relying on a vendor to ask them, what do I need to do? How? Sure. And ideally, my goal is to have you educated and empowered so that you can go to EHR vendors and say, I know that I need to accomplish this. How can you help me do that? Or how do I do that on your system? What buttons do I push to accomplish that? And not have to ask them what you need to do. So we talked about how the MIPS score can impact your fee schedule, but we also said that it's going to be publicly reported. Publicly reported so that anybody who wants that number can find it. And this is something to consider. And this is another situation where it's up to you. You have to decide how much of a threat or how much you care about this publicly reported deal. And I think it depends on your, how long you've been practicing, how much longer you're going to practice, what type of practice you're in, what type of community you're in, your current online presence. There's a lot to consider here. So it's up to you to decide. So we're going to give you just some thoughts about this publicly reported deal, and then you decide how you want to handle it. So it's going to be publicly reported. Anybody can look it up. The first thing to take into consideration is this Physician Compare website, which I put there if you want to look it up. So CMS built this Physician Compare website, and they're telling us that they are going to publish our MIPS scores there, and it sounds like they're going to make it look as though that is a reflection of the quality of care that we provide, which in my opinion is a joke. If you want to assess the quality of care that I provide, look at my post-op x-rays. But I think that's the way it's going to be painted, and that patients can doctor shop using Physician Compare. So that's something for you to consider. If a lot of people ask my opinion, so I'll share my opinion with you. My opinion is that website stinks. Today, maybe they'll fix it up. It is not user-friendly. It is difficult to navigate. I tried to find my own Physician Compare profile, and it was so difficult that I bailed and gave up. I still haven't even seen what my own thing looks like on there. So I don't think my patients are going to find it if I couldn't find it. But something to consider. Maybe they'll fix it up. But I think you'll agree with me that most people are finding us via Google, Health Grades, Rate MDs, Google+, right, all the other stuff that we do. But something to think about. CMS, and I make this point because it has been incorrectly reported that it happened, and it didn't. What did happen, and this is confirmed, is that CMS negotiated with Yelp, did not do anything, negotiated with Yelp to share our MIPS scores with them so that they could integrate that into their ranking algorithm or scoring algorithm. Now that has not happened, but it was discussed. Now that gets my attention, if you want my opinion. I care a lot more about Yelp than I do Physician Compare. So just something to keep an eye on. And then this is just us thinking, how else might this affect? Maybe potential employers, maybe. And in my mind, it's probably more likely to happen at like a big giant institution or hospital system where they might care about your MIPS score, maybe, I don't know. And then the biggest threat, in my mind, the biggest reason to consider this publicly reported is the threat of the private payers following Medicare's lead. Because don't they normally do that with everything else? CMS is doing all the work for them. They're collecting this nonsense. We're pushing the buttons for them. All they have to do is post it. Private payers, they certainly have the prerogative to also adjust fee schedules based on MIPS scores, or maybe even decide who they'll allow on their panels. And then I read this is all rumor, none of this has been published from anybody, just thinking maybe they'll do different copays based on your MIPS score to encourage people to go to providers that have better MIPS scores, lower copays. Just thoughts, just stuff to think about. And we make this point because so often we hear, well, my Medicare population is really low, I don't care. Let them hit me with 5%. I'm not pushing their buttons. Well, there's more to it than that. Or I'm totally going to stop seeing Medicare patients. All right, that's one way to go, but there's other things to consider. There's more to this. And we just tried to give you some ideas as to why this publicly reported option may be important. Now we're going to get into the stuff, right? I said you can click or not click, do or not do. Now we're going to get into what you actually do. As we go through this, you report, with one exception, on all of your patients. Even though the adjustment is only to your Medicare fee schedule, you have to report this stuff on all of your patients, regardless of their insurance, regardless of if they have insurance, doesn't matter. You report on every single person you see, with one exception, which we'll get to. And for those that know what I'm talking about, that exception is if you choose to report your quality measures via claims, you only have to report your quality measures on Medicare patients. If you don't know what that meant, that's fine. We're going to get there and explain it. But for those that have further along with the program, you understand what I just said. Some may be exempt from this in 2018. The threshold changed from 2017 to 2018. There are podiatrists who were in for 2017 that will be out for 2018 with this change. In 2017, the thresholds were $30,000, 100 beneficiaries. 2018, the thresholds went up, which to me was surprising, because this is going to eliminate more people. So, in order to be exempt in 2018, you're out if you had less than $90,000 in Part B allowable, or fewer than 200 Part B beneficiaries. Beneficiary is a patient, one person. If you see one person 10 times, that counts as one. So these are the thresholds. If you are, and that's an or, not and. So if you are under either of those, you are exempt from this program in 2018, which means you're out. You can do it if you want, but it will have what you do will have no impact on your 2020 fee schedule. Dr. Ward.
Jeff, if you're excluded, how is that reported out on the Yelp and all those things?
Doctor asked, if you meet this exclusion, how does it get reported? You do not get a MIPS score of 0. That would be bad. It is reported that you were exempt. That's what it shows. You were exempt, with no adjustment to your fee schedule. When you open up that Excel document on January 1, 2020, you'll get what it says, which isn't totally true because we're still under 2% sequestration. So you still have to subtract that 2%. So you would be reported as exempt with no adjustment to your fee schedule. I've done this in a couple places where I skipped this, and it turned out there were people in the room that it did apply to, and then I felt bad that I blew through it, so we're going to do it. If you were affected, and we're going to show you what affected means, if you were affected by any of these 3 hurricanes, when they happened, you are exempt for the 2017 reporting period. So the rule is, if you were affected, and I'll show you what affected means, for 2017, they know you were affected. You don't have to do anything. You don't have to submit anything. You don't have to apply for an exemption. You don't have to write a letter. You don't fill the application. You could do nothing, and you will have no penalty based on the 2017 reporting period if you were impacted by any of these hurricanes. If you were impacted by any of these hurricanes, you can also apply, now it's different, apply for an exception from the 2018 reporting period. Now you have to apply, and you are going to need to attest to the fact that whatever happened in September of 2017 negatively impacted your ability to participate in this program in 2018. And there are absolutely people that applies to, but you got to be careful with that. Those that were affected are all of the Virgin Islands, all of Florida, all of Georgia, all of Puerto Rico, certain counties of Texas, certain counties of South Carolina, and certain parishes in Louisiana. I think it's cute that Louisiana doesn't do counties. They do parishes. They roll a little different. So you have the handout. This is who was affected. Might not be anybody in the room, but if you were, you have that option. So here is what will determine our 2018 MIPS score if you are in a practice of greater than 15. I talked to some people ahead of time. I know that there are people in the room that are in a practice of greater than 15. So we're going to do both. If you're in a practice of greater than 15, these are the weights with which each of these 4 categories will determine your MIPS score. If you are new to the program and you didn't do anything last year, quality category looks very similar to PQRS. If you did PQRS in the past, the quality program looks very similar. ACI stands for Advancing Care Information. Advancing Care Information is the new meaningful use. Meaningful use for providers is dead. It doesn't exist. Meaningful use is now only a hospital, an institution thing. There's no such thing as meaningful use for us anymore. It was replaced by Advancing Care Information, and that deals with your EHR. That is the only category up there, ACI, which requires an EHR. You can participate in the other 3 categories without an EHR. So you don't have to have an EHR to do MIPS. That's a common question we get. You need to have an EHR to do Advancing Care Information. CPI stands for Clinical Practice Improvement Activities. These are activities that you can participate in that they think shows you're improving your practice. And the last category, which is new for 2018, is the cost category, which we'll touch on and only touch on it because nobody really understands it. Even them, admittedly, they still don't have that figured out. These are the 4 categories for 2018 if you're in a group of more than 15. You can see the weights with which they count towards your score. But a big change, which does apply to most of the people in the room, for 2018, and I think this is awesome, I'm doing it, because it makes it easier, and I suggest that you strongly consider it. If you are in a group of 15 or fewer, you can apply for an exemption from the Advancing Care Information category for 2018. This was part of their, we're going to ease the burden on smaller practices business, which for the most part is hogwash, but they actually did it here. So we'll give them a teeny bit of credit, just a hair of credit. For 2018, not last year, but for this year, if you're in a group of 15 or fewer, you can apply for an exemption from the ACI category, the one about your EHR. There's going to be an application for this. It's not out yet. Surprise, surprise. When it comes out, we will blast that out from APMA. You will get emails. You'll see it posted if you are a member and you're getting this information. And the link will be provided to fill out the application and send it in. In years past, this application has been shockingly easy. A 1-page or 2-page PDF document that you fill out and then email. They actually give you an email address to send this in. So they've made it really easy. I expect that this will be pretty easy once they release it. So 15 or fewer, you can apply for an exemption from the ACI category. If you do that, now you don't have Advancing Care Information. You only have 3 categories. And that 25% that you now no longer have to deal with moves to the quality category. So if you're in a group of 15 or fewer and you apply for the ACI exemption, because that makes this easier, I think, that 25% moves to quality. Sorry, that 25% moves to quality. And now this is what your pie chart looks like. If you're in a group of 15 or fewer and you apply for the exemption. Remember what the cutoff was to avoid a penalty for 2018? What was it? 15. Look at that clinical practice improvement activity category. So I'll tease where we're going here. If you are perfect in the clinical practice improvement activity category, that will earn you 15 MIPS points, which is all you need to avoid the penalty. One more small practice deal. If you're in a group of 15 or fewer, if you participate on any level, if you do something, you get an extra 5 points. If you're in a group of 15 or fewer. If you do nothing and don't do anything at all, you don't get the 5 and end up with a MIPS score of 5. You have to do something. So if you do the minimum and just do clinical practice improvement and get those 15 points, if you're in a group of 15 or fewer, you're actually going to get 20. Because if you participate on any level and you earn yourself any score, if you're 15 or fewer, you get 5 bonus points. That was a little small practice deal. All right, so before we get into the specific categories, questions on anything we covered so far? Please.
By clinician, you mean MD, podiatrist, nurse practitioner, everything?
Right. So when we talk about the practice, doctor asked who counts in the 15. So it's any eligible professional. Yes, MD, DO, DPM. I have the list of the allied health people, but I don't have it on this PowerPoint. Nurse practitioners are in. MAs are not. Nurse practitioners are definitely in. Physician's assistants are in. Anesthetists are in. I could pull up the list if there's interest beyond that. I tried to pick the things that we might have in our world. So yeah, MD, DO, DPM. Dr. McMahon.
If we do a perfect score and get 15 on the improvement activities,
Yeah,
and we're a small group under 15,
yeah,
and therefore score 20,
yeah.
do we get a bonus?
Right, all right, so Dr. McCann asked, if we get 15 from clinical practice improvement, but because we're 15 or fewer actually end up with 20, will we get a bonus? It depends, because it's graded on a curve. It depends on what everybody in the country does. You are guaranteed no penalty. But, again, a crazy exaggeration, because this isn't happening, if every provider in the country gets a MIPS score of 50, and you are the one exception of everybody in the country that got a 20, you're not getting a bonus. That's a crazy exaggeration to make the point that it depends. It depends on what everybody else does. All right, let's get into the categories, starting with quality, which counts for 50% if you're in a group of more than 15. It counts for 75% if you're in a group of 15 or fewer. There's a list of 271 quality categories. It's called quality measures. There's a list of 271 quality measures. If you want to fully participate in the quality category and max out your score in the quality category, you need to choose 6. We narrow down that list of 271 to a much, much, much shorter, more manageable list for you. So you don't have to choose from 271. We're going to give you 10 to 15 for you to choose from. They're on the slides. They're in your packet. If you want to fully participate. So what do we mean by fully participate? This was the flexibility that they gave us, right? You're drawing points from different parts of the program. I'm trying to calculate half of 75 in my head, and I'm having a hard time for some reason. 37 and a half. Okay, so let's say you are 15 or fewer, and the quality category counts for 75% for you, because you're 15 or fewer. It's 75% of 100. So if you're perfect in the quality category, if that's all you do, and you're perfect in the quality category, you have 75 MIPS points. 75% of 100. What was the threshold for exceptional performer? 7. So that's an option. But let's say you're not perfect and you don't max the quality category by doing 6, and instead you only do 3. If you are perfect on 3, half. 3 quality measures, you now have achieved half of the max quality category score. So you would get half of 75, and you would have 37.5 MIPS points. So that's what they meant by they gave us flexibility. You can choose to do all of quality only. You can choose to do half of quality. You can choose to do 2 quality measures. You can choose to not do quality at all and only do clinical practice improvement. So that's what we mean by if you want to max out the quality category. If you want the highest possible score from the quality category, which is 50 or 75, depending on the size of your group, you need 6 out of the 271 quality measures. One of the 6 needs to be an outcome measure. So there's 271 measures. Some of them are outcome measures. Of your 6, 1 has to be an outcome measure. If you choose 3, one of them needs to be an outcome measure if you want to max out those 3. And your measures, whether you choose 2 or 4 or 5 or 6, your measures all need to be capable of being reported by the same mechanism. They all have to be able to be reported to CMS, meaning how you tell them you did it, by the same mechanism. There's different mechanisms. There's different ways you can report this stuff. And we'll show you what we mean by that. These are the mechanisms, the means by which you can report the performance of your quality measures. You can do it via claims, by putting codes on your claim form. You can do it via registry, where you use something else to collect your information for you and submit for you. You can do it via EHR, or there's another option for those that are in a group of 25 or more. Most of us, if not all of us in the room, are going to be choosing between claims and registry. There are advantages and disadvantages to both of those. Dr. Christina is going to touch on that when he talks about registry reporting and the APMA registry. And there are many advantages to that and reasons why you should be engaged with the APMA registry. Both selfish reasons, why it helps you, because it's easier, and bigger reasons to how it can actually help the profession and help podiatry. But still, there are advantages and disadvantages to claims versus registry. We can talk about that. If you are going to participate in the quality category and you want to fully participate, again, you have to choose 6 measures. When you look at these measures, I said there's 271, and we're going to give you a shorter list. Every time you look at a measure, when you read the description of the measure, it will tell you how it can be reported. What is this measure's reporting mechanism options or option? So every measure you look at, you get a description of the measure, and then it says this one can be reported via claims. Or maybe it says this one can be reported via claims or registry. Or maybe it says registry only. Every measure has its own thing. Which mechanisms it can be reported by. Some are only claims, some are only registry, some are either or. So you have to decide, what is my reporting mechanism going to be? How am I going to report this? Do I want to do claims or do I want to do registry? Dr. Christina is going to help with that discussion when it's his turn. Once you make that decision on how you want to report, now you go shopping for your measures. And if you've decided on claims reporting, you need 6 that can all go in via claims. If you want registry and you're going to do 6, you need 6 measures that can all be reported via registry, because they all need to be capable of being reported by the same mechanism. If you want to max out this category, you need to report on 60% or more of your patients that qualify for your measures. And we'll get into what we mean by qualify. If you want to get a max score, you have to report on 60% or more of your patients that qualify for your categories. Last year it was 50. This year it's 60. The good news about this 60% business is, as we stand here on February 24, if you haven't done anything yet, it's not too late, right? Because we have way more than 60% of the year left. So you could start this on Monday, you could start this on March 2, and you still have the ability to get a perfect quality score. Because over the course of the year, you only need to report on 60% or more of your people that qualify for your measures. Here is where the one exception that we mentioned comes into play as far as reporting on all of your patients. Clinical practice improvement activities, every patient no matter what. Advancing care information, the EHR one, all of your patients no matter what. Quality, if you're reporting via registry, all of your patients regardless of their insurance. If you report via claims, by putting the code on your claim form, it's Medicare people only. Only Medicare people, if you're reporting via claims, if you're reporting your quality measures via claims. There's 271. We narrowed it down for you. I'm going to show you how to view the list. If you don't want to, don't do it. Skip it. You could just go from our list. I think there's some usefulness to going through this exercise, to seeing where they come from. If you want to look through and shop the measures on your own, this is how to do it. Again, we narrowed it down. You don't have to do this nonsense if you don't want to, but we're going to show you how in case you want to. This is the QPP website. Everybody in the room knows what QPP is, right? And because there are two ways by which you can participate in the quality payment program, we have MIPS and APMs, right? That's what we talked about. We are MIPS. That's what we care about, right? So if you want to look at these measures, you go to qpp.cms.gov. That's their website. It is, in my opinion, a very surprisingly user-friendly, good website. They got something right. This is totally different from every other Medicare website that exists. This is pretty well done and pretty easy to navigate. qpp.cms.gov. We're looking for quality measures right now. So you click on MIPS, because that's where we live. When you click on MIPS, it opens up this drop-down menu. You can see that one of the options is Explore Measures. We're looking for quality measures. Under Explore Measures are our three categories where there are measures: quality, advancing care information, clinical practice improvement. We care about quality. You click on quality and you get this list of 271 measures that are in alphabetical order. That's all you got, is their names in alphabetical order. And if you want to go through and do this, again, we did it for you, but if you want to, you go through this list, you look for ones that may be of interest to you. When you see one that's a winner, or potentially a winner, you click Add. When you click Add, it starts to populate this column to the side. So you go through, I saw acute otitis externa, I didn't click on that one. I didn't think that was a good one for us. I saw blood pressure management, I did click on that one. So that's what it looks like, right? So you go through the whole list, you fill up the column on the side, and when you're done, you have this list. So I ended up with 42. When you're done, you click that blue download button, and it will download onto your desktop the measures, their numbers, their descriptions, and then there's somewhere else you can go to get even more detail, but we're going to skip that for our purposes, again, because we already did it for you. You need 6. One of the 6 needs to be an outcome measure. All 6 need to be reported by the same mechanism, one of these mechanisms. I said we narrowed it down for you. If you choose to report via claims, these are 10 measures that we thought would be appropriate for podiatrists that can all be reported via claims. There's one outcome measure on there. It says you need an outcome measure unless there are no outcome measures that are applicable to the care that you provide. So we're going to give you 2 different takes on this, and then you decide what you're comfortable with. The only outcome measure that I could find out of 271, let me rephrase that. The only outcome measure I could find that could be reported via claims is this hemoglobin A1C measure, where we have to get the lab value and report on their A1C, whether it was under 7 or over 7. And that's an outcome measure. And I think that is applicable to our care enough that it would be difficult to make the argument if you didn't do this and you were audited that you might have a hard time saying, well, there weren't any. If they come and say, you didn't do an outcome measure, you say, well, that's okay because there weren't any that were applicable to my care. I'm worried about them saying, yes, there was, you could have done that one. But an even bigger reason for me is I don't want to have to worry about it. I just want one in there. And then nobody can come say, I didn't do an outcome measure. Dr. Christina doesn't totally agree with that, so let's give him a chance to voice his side.
So there's a couple problems with the hemoglobin A1C. First of all, we do not prescribe medications to control patients' diabetes. That's up to their primary care or their endocrinologist. So the fact that we don't do that, I don't think that's within our scope of practice technically. So I think you're fine. So I don't think you need to have I don't think you need to do that outcome measure. Now what it says is if there's not an outcome measure applicable, then you need to have at least one high priority measure. And there's several high priority measures on there. Falls prevention is one of those. The other thing about the hemoglobin A1C is since you don't control that patient and you have to report on at least 60% of your eligible patients, if that patient is out of control, that's going to give you a poor performance on that measure. It's going to affect your overall score. So why should you have to use a measure that you have no control over and can decrease the score that you might achieve? I don't think if you got audited, you'd have any problem. I don't think they expect you to actually treat the patient's diabetes. You're treating the systemic manifestations of diabetes in the lower extremity. So my opinion is, don't do A1C, do a high priority measure, and you'll be fine. But as Jeff said, you can, if you feel like you just don't want to take the risk, but I don't think you'd have any problems in an audit defending it. I think the odds of being audited for that are very, very low.
And I agree with the odds being very low deal. Thanks, Dr. Christina. So those are 10 claims eligible measures. Doctor.
I have a question. How is your office set up to get that information?
Okay, this is great. Doctor asked, how is the office set up to get that information? I'm going to answer that in about 3 slides. Important question, right? With nuts and bolts. How do I do this? I promised we were going to tackle that. So we'll get there. We're going to give you that. Those were 10 claims eligible measures. We pulled out 15 registry eligible measures. So if you choose to report via registry, the list you have in front of you is 15. There's one outcome measure on that list. And then the same conversation applies. There are some, now Dr. Christina is going to talk to you about the difference between just a registry and a QCDR, a qualified clinical data registry, which the APMA registry is, which is kind of a big deal. There are some registry measures that are only QCDR measures that are not on this list. Dr. Christina is going to get into that further. For our purposes, if just using a registry, these are your 15 measures from which you can, I suggest that you pull out 6. There is an outcome measure on there if you choose to go that route. If you are using a QCDR, which the APMA registry is, you have more options, which Dr. Christina is going to share with you. Now I'm going to get to Doctor's question. Once you've picked out your 6 measures, now you must intimately know your measures. 2, 3, however many you pick. If you pick out 6 measures, now you must know your measures inside out and backwards and know everything about your measures and how to report it. Like Doctor said, how to set up your office. How do you actually make this work to report the measure? So to model that, we'll pick one and we'll dissect a measure to show you what I mean by know it intimately and how to track this craziness. So I picked to model tobacco screening and cessation intervention. I thought that was one a lot of us might do. It's one I'm doing. I think it's an easy one. I picked this one. Tobacco screening, cessation intervention. Now you have to know your measures. And the first thing you need to know about all of your measures is the denominator. The denominator tells you, who do I perform this measure on? Who among all my patients do I have to ask if they use tobacco or not? That's what the denominator answers. Who goes into the denominator? Who do I have to ask about tobacco use? Who do I have to ask about their hemoglobin A1C? Blood pressure, right? Whichever ones you choose. Each measure has its own denominator. Some of them are different. You might have one measure with one denominator and a different measure with a totally different denominator. The denominator for this measure is over 18 and has one of those codes on their claim form. Don't be intimidated by that list, because all it is E&Ms. It's the evaluation and management codes that we know very well. 9920s, 9921s, we all know those, right? Those are E&M codes. Over 18 had an E&M. Now, if you're reporting via registry, the denominator for this one is over 18 and had an E&M. If you're reporting via claims, the denominator for this one is over 18, had an E&M, and Medicare. Somebody got it, right? Because if you're reporting via claims, you only do it on Medicare people. If you're reporting via claims, if the patient in the chair has private insurance, doesn't matter. You don't have to do it on them. That's your denominator for this measure. Over 18, had an E&M. If they don't meet the denominator, you don't have to perform the measure on that patient. If they come in and they get a 11721 and leave with no E&M, they didn't fall into the denominator for this. You don't have to report it on them. They don't go into the denominator. They don't count for you or against you in any way. And I'm making that point because we often get asked, well, now I have to start making up E&Ms if there wasn't one really there just to qualify them? No, don't ever do that. If an E&M didn't happen, they don't qualify, and that's fine. And that doesn't count in any way. They don't go in to your denominator. So that's the denominator. Now, if you identify this patient meets my measure denominator, now you have to perform that measure upon that patient, which for this one is to say, do you use tobacco? The hemoglobin A1C1 will be to get their most recent A1C value. You ask them if they use tobacco. Now, each of the measures also has a numerator. Reporting options with codes. Now I did it. Now I'm going to tell them that I did it. These are the numerators for this tobacco screening and cessation intervention measure. So let's look at the second one first, because it's really easy. They're a non-tobacco user. Do you use tobacco? They said no. Well, there's a code there, 1036F. So now you identified that they met the denominator. You asked them if they use tobacco. They said no. You have to document patient was screened for tobacco use and found to be a non-tobacco user. And then if you are reporting via claims, you have to put that code on your claim form. 1036F. Whatever diagnosis is pointing to the E&M, because there was an E&M if you did this, that same diagnosis points to the quality measure code, or codes, if you're doing multiple, if this patient qualifies for multiple. So whatever diagnosis, tinea pedis, right, B35.3, you could have that pointed to 99202, and that same diagnosis also pointing to 1036F, if they're a non-user. And of course, you have to document it. Now let's look at the top one. This is just one measure now, right? 1 out of 6. This is what I meant by know your measures intimately. Patient said they do use tobacco. Well, this measure calls for, if they are identified as a tobacco user, providing cessation intervention, which for this measure does not require writing a prescription, only requires providing cessation counseling. You provide them with counseling on their tobacco use, and you document that you provided counseling about their tobacco use. Whatever you do, right? I'm going to make this up. You can steal it if you want. This is kind of my template, just going by memory. Patient was identified as a tobacco user. We discussed their tobacco use. I explained that that can have a negative impact on lower extremity health and cardiovascular disease, and they should discuss options that exist to help them quit with their doctor. Something, right? You've provided cessation counseling. That's all you need to do. If you do that, you have to document it with something like I just spit out, and then code it. Now there's a different code, 4004F, for that one. The third one is if the situation is so dire and emergent you don't have the opportunity to do it. I think that's rare or never the case for us. And the last one is they were identified as a tobacco user and I didn't do anything about it, which is weird. It's an option. You'll get some points, but not as many as you could as if you actually perform the measure. So now let's answer Doctor's question. How do you do this, right? The most efficient way to do this is if you have an excellent electronic health record, where instead of doing what I just said, where you or your staff has to know your measures intimately, it knows your measures intimately. And you tell it what your 6 measures are. And it knows by the intake that was performed at the front desk, their age, whether they have diabetes or not, whatever other things that might fall into the denominators, right? It has all the intake information. It has past medical history. It knows who's in the chair. It knows by you punching it in or by the template that you choose if an E&M was performed. And it tells you what measures to perform, and you don't have to think about this craziness. Because if you're not doing that, now if your 6 measures are about, they have to be over 18, E&M, this one they have to have had diabetes, this one they have to have had a fall in the last 2 years. Now for every single patient, you're checking all 6 of your measures. Okay, the first one is over 18. All right, they're over 18, I'm going to do it. The next one is a diabetes thing, which is between 18 and 75 and they have diabetes. Now you got to figure that out. And you have to go through all your measures. So the best way and the most efficient way is to have an EHR, which allows you to tell it what your measures are, and then it prompts you. And then more efficiency, for example, would be it knows the patient's over 18 and had an E&M, you get a pop-up. Ask them if they use tobacco, doctor. Do you use tobacco? They say no, and you click one button, no. And it populates your note with the template, patient was screened for tobacco use and found to be a non-user, and it puts the claim on the claim form. Or if you're using registry, it sends that information to the registry for you. That's efficiency. If you don't have that in place, now you have to have a checkbox system, which I would suggest should be done by staff, not the doctor, because now this gets to be crazy. And now somebody, maybe the person who's rooming them, MA, whatever, knows what your 6 measures are, and now they start crossing them off for every single patient. Are they over 18? And then it depends on what your measures are. And again, different measures have different denominators. So you might have one patient that qualifies for all 6 of your measures, and you do all of them. You might have another patient that only qualifies for 2. So we'll do an example on that. This one's 18 or over, had an E&M. The diabetes ones, like diabetic foot exam, is between 18 and 75, has diabetes, and had an E&M. So if you see an 80-year-old patient, that patient qualifies for the tobacco one, they don't qualify for the diabetes one. You would only do the one of the 2. If you see another patient that's 50 and has diabetes, now you have to do both on them. So you'll have different denominators, if you're still with me on this. I think we're getting a little bit into the weeds now, but important for those that are still following, that you'll have different denominators for each of them because different people qualify for your different measures. So it depends on your practice. Efficiency is using an EHR to help you, or you have some sort of checklist in place where the person that walks in the room knows what the measures are, knows which questions to ask, then you have to document your performance and code the performance or be aligned with a registry where you can click the box that you did it.
Going back to that A1C.
Yeah.
So you go to have the staff call the doctor, send over
Yeah.
the number.
Yeah, okay, so doctor asks for the A1C. Do you need the lab value? You do. You are not supposed to go by what the patient tells you. You're supposed to get the lab value. Are you going to tell me I told you something different last year? No. Oh, good. 'Cause I may have.
It says recent lab value. Does that have like a 3-month?
Correct. So question was, it says recent hemoglobin A1C. Is there a statute of limitations on that? I am not aware. Anybody going to correct me? No? I am not aware of a timeline on that. We get to judge that. A year feels good to me. I'm totally making that up. That's based on nothing. I have no source to support that. Just feels right. I would ask them, have you had an A1C in the last year? I'm not aware of a timeline that they give us on that. Dr. Christina.
Just the A1C, you need the documentation on. Smoking cessation, you can take the patient's word for it. They can come in with a pack of cigarettes, smell of tobacco, if they tell you no, you can put no in there. That's patient reported versus having to have the documentation.
So I'll repeat that for those on video. Dr. Christina shared, for A1C, you have to have the lab value documented from the lab. Tobacco, that you can just do on your own. And that goes back to what Dr. Christina said about if you want to score high and have a better score, you want to pick measures that you can have an impact on, which is another reason to thank and support APMA, because they developed measures like the diabetic foot exam measure that we can actually impact. So we have our own measures. Any questions on quality? Dr. Tower.
Where do you actually go to get those codes and measure specifications?
So I don't have a screenshot. All right, the question was, where do you go to get the specifications? If you are an APMA member, it's all done for you very cleanly and neatly. If you want to write this down, this is not in your packet. If you go to apma.org /MIPS 2018, MIPS 2018, apma.org /MIPS 2018. So we just showed you the specifications. What do we mean by specifications? We just showed you the specifications for 1. If you're going to choose 6, you need denominator, numerator, who qualifies, code for all 6. We only gave you 1 because no sense going through all of them. I think you get the idea. On that website, apma.org /MIPS 2018, you'll see quality measures and then a claims list and a registry list, and you get the PDFs with all of those for all the measures that we gave on those lists, with the 10 for claims, the 15 for registry. Event, yes, please.
Oh, you can finish your thought.
No.
I just said, does this only have to be report, like, so a patient comes in January?
Yes.
6 months later,
Oh,
you have to do it once?
I'm so glad you asked that. The question was, what if you see the person multiple times? Do you have to do it once or do you have to do it every time? It depends on the measure. So now we go back to measure specifications. Every single one of them, and they actually make it really clear and easy, believe it or not, every measure in bold, in the first sentence of every descriptions measure, it says, once during the reporting period, or it says, for every encounter during the reporting period. They actually did it in English and made it really easy to understand. So if it says once per reporting period, if you see them and they qualify 15 times, you only have to do it once. And it doesn't matter if it's the 5th time or the 7th time. If it says for each encounter during the reporting period, then you have to do it every time you see them that they qualify during the reporting period. Did you want to add something? Gail?
Yeah, it would also just be really certain you're reading the measure specification for the correct method of reporting that you're utilizing, because I remember last year with the smoking cessation one?
Yeah.
For the claims reporting, you only needed to report on it once for the patient.
Right.
But if you're reporting via registry, you needed to report on it at least twice.
Right.
So you need to make sure you're looking at the correct specification.
Right.
For the method you're reporting by.
So Gail Reese, APMA Health Policy and Practice Department, thank you for pointing this out. Know your measures intimately. So the point Gail made, which is crazy, is that when you look at the PDF for the tobacco measure reported via claims, the specifications, it's different for the specifications for the tobacco measure reported via registry. And the one for claims says once during the reporting period, and the same measure reported via registry says you have to do it twice during the reporting period. So know your measures, the descriptions, the PDFs are on that website.
And similar to it being in bold, how many times you might have to report on it, at the very top of the measure, it'll say this is for registry only or this is for claims only. So it'll be very clear when you're looking at the specification and the title, which one it's for.
So Gail pointed out when you download that PDF, when you look at the specification, it will very clearly say that measure via claims or that measure via registry. It's easy if you go through the APMA site using your membership because they're listed by either claims or registry. Makes it easy. We'll get into advancing care information, the new meaningful use. This is the one that you must have EHR in order to do, and this is the one that you can claim an exemption for if you're in a practice of 15 or fewer, which I suggested you do, because why not cut out some of this craziness? If you're in a practice of more than 15, you don't have that option. This is the new meaningful use. This looks very similar to meaningful use. There's a list of measures. If you did meaningful use, you will remember this 50% for reporting, 50% of performance business. So we'll pick one to use as an example, and that is the summary of care document thing, that if you have a visit with a patient, if you have an E&M with a patient, you need to provide that patient with a summary of care document within 5 business days of their visit. So what they mean by 50% reporting, 50% performance is if you report, I had 100 E&Ms, 4 of them got a summary of care document within 5 business days, you reported, you'll get half the credit just for reporting that, but your performance won't be good because you only got 5 out of 100. If you report, I had 100 E&Ms, 99 of them got a summary of care document within 5 business days, you will have reported and you'll have good performance. So that's how this category is scored. We're going to give you the measures. We can go more quickly now. You went through this exercise. If you want to look them up yourself, website, MIPS, measures. Now we're in advancing care information. Let's spend a moment talking about your EHR. Your EHR is either 2014 certified or 2015 certified, which is weird because it's 2018. The year of the certification has nothing to do with the year we're currently in. That's just what they're called. They could be called Z certification and V certification. They just happen to have assigned year values to it. So your EHR is 2014 certified or 2015 certified. If you are participating in the advancing care information category, you need to know whether it's 2014 certified or 2015 certified. If you don't know, that's a question for your vendor. Which certification does my product have? Most are 2014, especially the podiatry specific ones, are 2014 certified. If you are doing this category and you are using 2014 certified technology, there are 4 mandatory measures. Mandatory meaning if you want to fully participate in this category and get points from this category, you have to do these 4. If you are using 2015 certified technology, there are 5 required measures. So there's another one that's not listed here. I don't think very many of us have 15 certified technology, which is why I didn't list it. So if you're doing this category and you're using 2014 certified EHR, these 4 are mandatory. Happens to work out that if you do the 4 mandatory ones only, that is not enough to max out this category. So if you want to max out this category, you have to do more than what is mandatory, and there's a list of more measures that you can choose from to get more points within this category if you want to get to the max. This is something your vendor should be helping you with. This is all the HR stuff. It's why I go shorter on this than the other 2 categories when we do this. A lot of this is dependent on your EHR, but we've given you the measures. And we've given you the knowledge of, I need to know which certification I have. I need to know that if I'm less than 15, I can get out of this whole deal. But if I'm more than 15, I have to worry about it. And know what your certification is, know how many mandatory you have, and that you need more than the minimum in order to score perfect in this category. And then we come to clinical practice improvement, which I think is the easiest of all this, which works out nicely, because with it counting for 15% of your possible 100, if you're perfect, you get 15 MIPS points. And in order to avoid a penalty in 2018, you need 15 MIPS points. These are activities that you can choose to perform and then report that you did it. There are 93 activities from which you can choose. We narrowed down the list for you. I think it's 14, the list that we narrowed it down to. We narrowed it down for you. There are 93 of these from which you can choose. All of them are either medium weight activities or high weight activities. So the list of 93, every single one of them is either medium or high. Medium weight activities count for 10. All right, wait, I'm going to take a step back. Okay, now we're within the clinical practice improvement activity category, right? We have the 4 categories under MIPS. We're just in clinical practice improvement. And we're going to try to be perfect in the clinical practice improvement activity category in order to earn 15 MIPS points. This clinical practice improvement activity category has its own scoring system, just within CPIA now. It has its own scoring system. If you want to be perfect in the CPIA category, in order to earn 15 MIPS points, you need 40 CPIA points. To have a perfect clinical practice improvement activity score, so that you get 15 MIPS points, you need 40 clinical practice improvement activity points. So if you want to be perfect, which I think most of us are going to be gunning for, because this is easy, we want 40 CPIA points. So now we have 93 measures. All of them are either medium or high. The medium weight measures count as 10 CPIA points. The high weight activities count as 20. We're trying to get to 40. High weight count as 20 CPIA points, unless you are in a group of 15 or fewer, including solo practitioner, in which case you get to double those. This is good. If you are in a group of 15 or fewer, a medium weight activity for you counts as 20 CPIA. One high weight activity counts for 40 CPIA. And what do we need to be perfect in this category? 40. So if you're 15 or fewer or solo and you do one high weight activity, you got it. You got 15 MIPS points and no penalty in 2020. This is what I meant when I said an hour and 20 minutes ago that you could do this very easily. Medium 10, high 20, unless you're 15 or fewer, and then medium's 20 and high is 40. I think we got this, right? You get the idea. Let's go to the bottom one, because I know there are people in bigger groups here, but if you're 15 or fewer, you only need one high or two medium, 20 plus 20, right? We narrowed this down to 14. I'm going to ask you to do something for me. Dr. Tower gets credit for this. On your list, in your packet, please cross off number 15. I am no longer suggesting that. There's part of it that's weird that Dr. Tower pointed out to me. So we're going to eliminate that one as a suggestion. I do not suggest that you consider that one because there's something weird about it. So we narrowed it down to 14. I narrowed it down even more by putting the ones in red that I think are super easy. Super, super easy. The ones that are in red here. So please look at number 1, which is a high weight activity. What number 1 requires is that the patient has 24/7 access to you or somebody covering for you, and you or that covering person has 24/7 access to their health information, that means your EHR. They can get, so that's an answering service, right? They can get you 24/7. You can get into their EHR 24/7, and you offer same or next day appointments for urgent needs. That's it. Now, you need to be able to access the EHR 24/7. 24/7 doesn't just mean that you can dial in from home. 24/7 to me, if I'm an auditor, means if I'm on call and I go to the movies, I can get into the EHR, which to me sounds like you need to be able to access it on your phone or tablet. They can get you 24/7, you can get into the EHR 24/7, and you offer same or next day appointments for urgent needs. You're done. You got 15 MIPS points. That's high if you're in a group of more than 15, right? Number 3 is another super easy one, which I hope you're all doing anyway. We are specialists. Send specialist reports back to the referring doctor. That's good practice management. You should be doing that anyway. That's a medium weight measure. If you're 15 or fewer, you're halfway there. Dr. Tower, sorry, you wanted to add something.
Well, for something like number 3, where it's easy to track that,
Yeah.
so to speak, when did that message, when was that sent?
Right.
How would you document number 1?
Yeah.
If somebody were to come and ask down the road?
So Dr. Tower asked about documenting these, right? With the quality measure stuff, it was much clearer. You do it, you document it, you put a code on. These are attestations. The performance of your clinical practice improvement activity is an attestation. You are going to go on a website, hopefully the APMA registry, and click a box to say, I solemnly swear that I did this in 2018. You could do it on the CMS site and fight through their nonsense. You could do it on the APMA registry, which is way cleaner and easier, and attest. Username, password, list of activities, click the box, I solemnly swear that I did this in 2018. And in the case of an audit, you need to be able to prove that you did it. So an auditor, for example, would come to the office and say, you told me that you could access 24/7, let me see, get your phone out. If you were at the movies when you were on call, how would you have gotten into the system? That's an audit. Or you attested to having sent reports back to specialists. Give me 15 referrals and show me the letter that went back to the specialist for all 15. That's how these improvement activities work. So another super easy one, number 7, patient experience surveys. Give them a survey. How many rings did it take before they answered the phone? Were you greeted with a smile at the front desk? Did the doctor answer your questions? Did the doctor spend enough time with you? Whatever. Touchy-feely stuff. Do a survey. It's a good practice management tool anyway to do that and get feedback on patients' experience at your practice. That's medium. Halfway there if you're in a group of 15 or fewer. Then number 7 and 8, many states now require you to be compliant with the state's prescription drug monitoring program. Even if they don't require you, do it. It's a good thing to do. You will help with the opioid situation, and it makes it super easy to do this. So if you're in a state that requires you to sign up with the state's prescription drug monitoring program and query the program every time you write for an opioid, you're already done. You might have 15 MIPS points sitting here right now and you didn't even realize it. So number 7 is signing up and using it. Number 8 is every time you consider writing an opioid or you write an opioid, you log in, you put in the patient's name. Again, not you. Should be staff, not the doctor. I know there's non-docs, there's staff in the room, but my suggestion is staff should be doing this. Query, look it up, check the box and attest that you did it. Number 8 is the whole deal. High priority. 15 MIPS points if you're 15 or fewer. But even if you're more than 15, I know there's more than 15 practices here, there's high ones that are easy. You combine 2 high ones and you're there. And then number 12, fall screening, which I know a lot of people are already doing. There was a question over here, sorry.
Let's go back to the slide before. So you have 2 7s and 2 8s.
Oh, sorry.
Go back and explain those all over again.
Oh, sorry, I messed up the numbers. My bad. I said number 7, but there were 2 number 7s. So let's.
I was writing on one while you were talking
I understand.
on the other, and then.
All right, we'll fix that for the next one. The surveys. Surveys, I mentioned, give them a survey that assesses their experience at your office. And then the prescription drug monitoring program, one of which is signing up for it and putting in patient information, looking stuff up. The second one, which is consultation, is you register, and then every single time you're going to consider writing an opioid, or you do write an opioid, you query that prescription drug monitoring system to see if they just got 100 yesterday from somebody else. So we narrowed it down, pick the number that you need to be perfect. This is why I say nobody should get a penalty, because it's super easy to do at least the minimum to max out that clinical practice improvement activity category. Just wanted to make this point. I mentioned the 2014 or 2015 certification for your electronic health record. When the proposed rule for this came out, which is before it's official, they said they were not going to allow 2014 certified EHRs for this year. That is not the case. They changed that, and just in case you heard that somewhere, or you had a 2015 certified vendor trying to get you, 2014 certified technology is allowed this year. And then the cost. Yes, Dr. McCann.
The prescription drug monitoring.
Yeah.
I assume it's only prescriptions have to be queried or opioids.
The question was, do you only have to query opioid prescriptions? Correct.
And also, it's a 90-day reporting period, is that right?
So Dr. McCann asked about the reporting period, which we're getting to. Yes, it is a 90-day reporting period for clinical practice improvement activities. I have a slide on it, but we'll say it now. The reporting period for quality is the entire year. For 2018, the reporting period for quality is the whole year. The reporting period for advancing care information and clinical practice improvement is 90 days.
And even if you just wrote 5 prescriptions during the 90 days and
Yeah.
queried all 5,
Correct.
all insurances, you're still okay.
That's right. So Dr. McCann asked, what if you don't do a lot of opioids? What if you only write for 5 in your 90-day reporting period? Or even in the whole year, if you query all 5, have you met it? Absolutely. Yes, it is numerator, denominator. There's no volume. They're certainly not encouraging us to write more. That's for darn sure. So you just have to hit it for all. This cost category, we had a CMS MIPS person at our APMA CAC PIAC meeting in November, and he stood at the podium and said in November, we still don't have this calculation totally figured out. It's on tape. You can watch it on the APMA website. It's recorded. He said that. They still don't have this totally figured out. I'm going to tell you what we know. I asked for questions, but don't ask any questions on this part. Because nobody knows. I'll tell you what we know. I suggest you put very little thought into this because it only counts for 10% in 2018. It is scheduled to count for 30% in 2019. However, this just passed in the Budget Act. This was part of the Budget Act that was, like 8 days ago signed? In that new budget, the new budget that was signed, it gives the Secretary of Health and Human Services the option to change that 30% in 2019 back down to 10%, and he already said he's probably going to do it. The acting AZAR, the acting secretary. It's only 10%. It's difficult or impossible to figure out. I don't suggest putting a lot of credence into this, but like I said, I'll tell you what we know. They're going to calculate this based on 2 things. One is Medicare spending per beneficiary, and the other is per capita cost measures. Medicare spending per beneficiary deals with the amount of money spent only 3 days prior to hospital admission, during the admission, and 30 days after admission. They're tracking this. The only thing I take from this is it was interesting to me, they care about this. There's something there. They've clearly identified this period as one of high cost. This is what they care about. If somebody goes in 3 days prior to, through admission, and 30 days after, that must be a high cost thing. I thought about readmissions. These are just my own thoughts now I'm sharing. The 30 days after, they don't want people landing back in, maybe. Just something to think about. Try to keep your people out of the hospital. We're doing that anyway, right? And then the other total per capita cost is all the dollars that are spent in care of your patients. It does say specialty adjusted, which hopefully answers the question all of us have. What if my out of control A1C 14 diabetic foot ulcer disaster patient lands in the hospital with ketoacidosis and I have nothing to do with it? Am I going to get knocked for that? We hope that specialty adjusted means no. We hope. Here are the reporting periods that were just mentioned. Quality is the whole year. Remember, to be perfect in quality, you only have to report on 60% or more of your people that qualify. So even though it's the whole year, if you haven't started yet, or you're going to take 2 weeks to get yourself together after this conference and then start, you're still cool. You still can max this out. Costs, they're going to track those numbers for the whole year. Other two categories are only 90 days. Dr. Christina is going to talk to us about registry reporting, the advantages of registry reporting, and specifically the APMA registry. We have lots of time, which is great. This is exactly what we wanted. Before Dr. Christina comes up, questions on the content that I covered or thoughts? Dr. Urbis.
I have a part-time physician.
Yes.
And she didn't meet the 30,000 for 2017, the 30,000 Medicare.
Right.
So she doesn't have to report. But we did MIPS for her anyway.
Yes.
Doesn't matter. She will not get bonus.
Okay, so Dr. asked, employee for 2017, and same holds true for this year, employee for 2017 didn't meet the threshold. She collected less than $30,000 in Medicare Part B allowable, but they did it anyway. What happens to her? She has a MIPS score. That MIPS score will be publicly reported, but it will have no impact on her fee schedule. So even though she did it, her 2019 fee schedule will not be adjusted. But she gets a MIPS score, and it's publicly reported, and if any of the things I thought about or mentioned come down, that's good for her that she did it. Dr. Ward.
How does it apply if you're a hospital employee? Are you with the 15-member group? Are you part of, there's 3 podiatrists employed by the hospital, or all the providers employed by the hospital?
Right, so Dr. Ward asked, what if you are hospital employed in a big giant group? So that depends on how you choose to report. So you can report as an individual, or you can report as a group. If you report as an individual, what you do impacts you only, and the adjustment will only be to your fee schedule. If you report as a group, now it depends on, and Dr. Ward asked, what about the size of the group? It depends on how many providers are billing under that group's TIN, tax ID number. It depends on how many employees are billing under that TIN. For hospital employed, it's normally everybody, because that's to their advantage to have more people going in. So that's probably a huge group. So if you are hospital employed and they want you to report as part of their group, now you have interest in what everybody else is doing. And you have interest in the systems they have put in place to ensure a good score for everybody, because everybody's going to have the same score if you report as a group. And there are advantages and disadvantages to that also, depending on if everybody's in and participating. Please.
And this may be making sense. When you said Yelp might be
Yeah.
putting that information out
Well,
there, how will, like, the common everyday person know to go look that up?
yeah, okay, so the question was if, and again, this is not happening today. I only mention it because it's just something to think about. The question was, if one of these online ranking websites does choose to incorporate MIPS scores, how would anybody know to go look that up? They wouldn't. And to me, if one of these websites starts listing your ranking, how much people like you, and your MIPS score, to me, that means nothing, because nobody knows what that means, in my opinion. However, if one of these websites just gives you one score, like Yelp. What is Yelp? 1 through 5? Somebody knows. Yes, 1 through 5. So you go on Yelp and you look at a restaurant and it says 4.6. Now, if the doctor's overall ranking takes MIPS into account, that's a way that it could impact your score without patients even knowing.
How about health grades?
Question was about health grades. Health grades we actually communicated with directly, and we have an email from them, it is 6 months ago, that says, 6 months ago, we have no plans of using MIPS scores as any part of our ranking. We have that from them. I wrote to them. Dr. McKeon.
If you're reporting on measures, a group of measures, and it says that it's for Medicare patients only, that would be Part B, not Medicare replacement?
Okay, so the question was, if you're reporting via claims, and because you're reporting via claims, you only have to do Medicare, is that just regular Medicare or Medicare Advantage only? It's Part B Medicare only. You do not have to do Medicare Advantage, these weird Medicares, whatever the other ones are. Medicare Part B only for quality measures via claims. Dr. Jim Christina is the CEO and Executive Director of the APMA, and he's going to talk to us about registry reporting.
So Jeff mentioned that APMA has developed a registry, and he mentioned there's different types of registries. So basically there's two types of registries. There's what's called qualified registries, and then there's qualified clinical data registries, or QCDRs. The qualified registries only report MIPS measures, and each registry goes through a process where they apply to CMS and they get designated as a qualified registry. They don't have to report on all MIPS measures. They may choose to report all MIPS measures, or they may just choose to report certain MIPS measures. If it's a qualified registry and say it's associated with ophthalmology, they may only report MIPS measures that they think are appropriate for ophthalmologists. A qualified clinical data registry, which is what the APMA registry is, can report on both MIPS measures and non-MIPS measures, or what they call QCDR measures. And those can be measures that have been developed to get more data on particular things. For example, in the APMA Qualified Clinical Data Registry, we have a comprehensive diabetic foot exam. That's a non-MIPS measure. You won't find that measure in the list of MIPS measures, but we think it's an important measure to start to collect data on, because the process of becoming a measure that's included in the MIPS program means you have to go through a process where you actually go to something called the National Quality Form. You get the measure endorsed by NQF, and typically then when you submit it to CMS, they will accept it as a MIPS measure, so it could become part of those MIPS measures. The downside of QCDR or non-MIPS measures are if they can't benchmark that measure. So one of the things that gets a little bit into the technicalities of these measures, when you're trying to do a measure, so you've picked your 6 measures and the maximum points you can get on that measure is 10, that's based on your performance on that measure. And for some measures, if they're very high performing measures, you need to get a benchmark score of like 90 or almost 100% to get those full 10 points. If they can't come up with that benchmark, and they can't on QCDR measures that don't have enough data on them, then they will only give you 3 points for that measure. The same as if you just did one measure on one patient. You get those 3 points. So it's important, like if you look at the APMA registry, you could choose to report data on the comprehensive diabetic foot exam, but I wouldn't include that in the measures. You can report data to a registry on more than 6 measures, but you want to choose your 6 best to actually report to CMS. So all a registry is it collects data. And the APMA registry, the way we've built the registry, is one piece of it is to collect data to allow you to submit your data to CMS for MIPS. And as we went over, for 2018, there's 4 components to MIPS. The cost component, you don't have to do anything. Somehow they're going to calculate that for you. As Jeff said, we're not sure how they're going to do it, but they're going to do it somehow. You're going to get a cost score, and your cost score will give you 0 to 10 MIPS points. It's worth 10%. The other 3 components, you have as you went over, you have the improvement activities, you have the ACI. Those are attestations. The APMA registry will allow any member to submit through the registry to go in and do your attestation, and then the registry will submit that data to CMS for you. That doesn't cost you anything. It's a member benefit, so you can go in, you sign up for the registry, you then, once you're all signed up and everything, you'll log into the registry page, you'll see your dashboard page, you'll see a spot to attest. You can go in and attest to ACI and improvement activities. Yeah, question?
So you can do your attestations through the APMA registry, yet for the other scores still submitted on claims. Is that correct? Or is
Correct.
it-
So the question is about the quality component. If you do 2 components through the registry, could you still do the other component through claims? Absolutely. You could do it through claims. You could do it through a different registry. You could also do it direct to CMS if your EHR is set up to download the file that will allow you to submit your quality data directly to CMS. APMA has also been working with the various vendors to try to get them to integrate with the APMA registry. And what that means is if they integrate with the registry, you'll have the ability to directly send that 3rd component, the quality component, to the registry seamlessly from your EHR to the registry. So the other thing is that in the APMA registry, this year for 2017, we had 11 measures in there. We've expanded it for 2018. So we have 18 different measures that you can report on through the APMA registry. We think these 18 are probably the most common ones that a podiatrist would use. So there's 18 that you can use. If one of your measures is not on this list, and you're going to use the APMA registry, you're not going to be able to report that measure to the APMA registry. You'd have to find another mechanism to report those quality measures. But as you can see, these are pretty common ones that everybody should be able to perform and are applicable to podiatry. And these are the non-MIPS measures that we have in the APMA registry. So you see the first one is the diabetic foot and ankle care, the comprehensive diabetic foot exam. That's a non-measure. We'd love to get the data on that measure. We don't recommend that you use it to report to MIPS, but we want to collect this data because the other component of the registry is to collect data and use that data. As Jeff said, one of the things that's going to be coming up are these alternative payment models. So some of these alternative payment models may eventually come to fruition to be almost a diagnosis-related group like a hospital does, so that you would get one payment, say for a heel pain patient. And so patient comes in, they have a diagnosis of plantar fasciitis, and you're going to get one payment for the course of treatment of that patient. How are they going to come up with the reimbursement amount for that? They're going to have to use data, and we're going to have data argue with them to say the typical heel pain patient should include reimbursement for at least 5 office visits, 2 injections, 3 strappings, physical therapy, orthotics, whatever. But we need to get that data so we can show them that this is an episode of care for heel pain that typically happens. And that's how we'll start to use all the data that we get. We also want to show that we do certain things. So if we go back to this list here, when you talk about falls prevention. So falls prevention is a big entree into these alternative payment models, these value-based payment systems, because it costs insurers a lot of money. So if you're doing the falls measure and we collect that in the registry, we can say, look, we have data in our registry. 2,000 of our members did the falls prevention measures. And so that gives us an entree into these other payment models. The other two that we've gotten are from another company that allowed us to use these. One has to do with ankle orthosis for ambulation and functional improvement, and the other has to do with functional outcome with foot orthotics. So those are just two other ones. Again, they're probably not, unless we have a lot of people that put in a lot of data on these, they're not going to get benchmarked. If they don't get benchmarked, you're not going to be able to get your highest performance score. The other thing that we did, if you noticed in 2017, there were what they called these measure sets for different specialties. Well, there wasn't one for podiatry in 2017. So we petitioned CMS and we came up with a list of 6 measures that we thought were applicable to podiatry. 2 of the measures are our measures that we developed, 126 and 127. That has to do with the neurological exam of a patient with diabetes and evaluation of footwear. Very easy measures, easy to do on your patients with diabetes. Then we put in the BMI because we made the point that obviously if you have a high BMI, you have a higher risk for diabetes, so it's related to something that we deal with. The falls risk assessment, obviously patients that have diabetes and loss of protective sensation are at greater risk for falls. We think that's a very important measure. That's also a high performance measure. And then the final one we put in was the tobacco care and screening. If you do a measure set, that's it. We have 6 in our measure set. You do those 6 measures in the podiatry measure set, I would recommend doing those. All of those in there are, you do them once per reporting period. So once you've seen the patient and you've done it, then you're done with it. There's a couple caveats with this. One of the things that Dr. Lehrman talked about was, yes, you might have a patient that comes in for a 11721 and the measure has an E&M associated with it, so you don't have to worry about that patient. You don't have to worry about that patient for that visit. They could come in later in the year and maybe they came in because they've got tinea pedis, or they come in because they have heel pain, and suddenly that patient that you normally are seeing for their covered diabetic foot care is now getting an E&M service. They now become an eligible patient for all the codes that are related to E&Ms. The other thing is the first 2 measures, 126 and 127, because we developed them, if you look at the denominators of the specifications of those measures, it includes our typical foot care procedures that we do, 11720, 11721, 11056. So you could have a patient that's a non-E&M patient and you'd have to just report those 2 measures on that particular visit. Does everybody understand that? It's a little bit, the eligibility depends, it's per visit. It's not an eligible patient or not an eligible patient for a particular year. Improvement activities. So Jeff talked about doing some improvement activities. I think the fall screening is a good one to do. Again, we're trying to collect data on doing this. So you do the fall screening and you do the appropriate things. That's a medium weight. That gets you halfway there to what you have to do. You pair that with your prescription drug monitoring, and you'll be right where you need to be in terms of getting your full 15 points for improvement activities, which, as he said, you'll get an additional 5 because you did one of the things. So you really end up with a score of 20. One of the other things he didn't talk about, because it gets a little bit complicated, but another way you could avoid the penalty is doing claims. Last year it was just 1 claim. You do 1 measure on 1 patient through the claim system. Well, technically, if you do 6 measures on 1 patient, you're going to get 3 points for each of those measures. 6 times 3 is 18. 18 out of 60 is 3/10, 0.3. 0.3 times 50 is 15. So you will get there with the math. If you do, you could pick 6 measures that you can do by claims. You could have 1 eligible E&M visit on 1 patient. You could document those 6 measures, and you also will avoid the penalty. It's just an alternative way to do it. It gets a little more complicated because you got to make sure you got an eligible E&M. It's a Medicare Part B patient because you're doing it for claims, and then you have to make sure you document all 6 measures and the patient is eligible for those 6 measures. But it can be done that way, and that would get you to, again, score 15, you participated in one of the things, you'll get a 20. You might want to do both. So if you do the improvement activities, which is pretty easy to do, particularly if you have to register for prescription drug monitoring, you get 20 for that one. You do the other one, you get another 15. Now you got a MIPS score of 35. You didn't have to do that much work, and you may get some bonus points for that. So this is how you do the APMA registry. So you basically go to the sign-up portal, go to apma.org/registry, and you'll get to the sign-up portal. You'll sign up. There's some information that you have to fill out about your practice. You'll then click. There's also a business associate data use agreement that you click on. Once you do all that, you'll be signed up to the registry. You'll get an email. It'll tell you how to go into the registry itself, set up a password, and do all those things. Once you get in there, then you're going to be able to go ahead and do your attestation, or over the course of the year, you'll be able to track the measures that are being reported and those types of things. It is open now. If you signed up for 2018, you should have been going through the sign-up process. So if you haven't done that and you signed up for 2017, or if you haven't gotten the information on that, get in touch with us and we'll help you work through the process. Dr. Towers put together an exhaustive instruction manual that tells you how to do everything. Yes, sir?
For 2017, are there any attestations that need to be done, or is there a deadline for that?
Yes, the question is for 2017, are there attestations that need to be done? Yes, if you did improvement activities or advancing care information, you need to attest. You can attest directly with CMS. You have to have your EIDM number and you have to be able to navigate through that. Or if you signed up through the registry, you can attest directly through the registry. The deadline technically is March 31st. If you're using our registry, we're requiring a deadline of March 24th so we can calculate all the data and then get the transmission to CMS by the 31st of March. But there are deadlines. It's typically, so for 2018, typically the reporting period for reporting all this information is the first 3 months of the following year. No advantage to reporting it earlier on in the first 3 months because they're not going to be able to calculate anything until you get to that point. The other thing to realize is if you did claim submission, so say you were just trying to avoid the penalty, you can go in right now and check to see what your MIPS score was based on claims. They have a website on the CMS website. Again, you have to have your EIDM number. If you don't have one of those, it'll give you instructions on how to do it. You can go in. I did have a doctor that contacted me about it. I walked him through going through the system. He went on and lo and behold, because he said, I just want to be sure I only did a couple patients with smoking. I want to make sure I'm not getting penalized next year. He looked, he had a MIPS score of 3, so he's not going to get penalized. Yeah, Gail.
Forgive me if Jeff already covered this, but if you submitted any quality measures via claims, the last date for 2017, the last date to do so is by March 1st, 2018. So if you haven't done it yet and you want to avoid the penalty.
Right. So the point that Gail is making, that if to submit your claims, if you're going to do quality by claims, March 1st is the deadline. What I was referring to is if you're going to do registry type reporting, those types of things, March 31st. But claims, and technically, you're probably not supposed to hold claims more than 6 months, is that correct? So this would be claims that you did in the last 3 months of the quarter or whatever. You get those in by March 1st. So the other thing that we're going to do is if you didn't sign up for the APMA registry, we're going to open that up for reporting, for signing up again, probably March 3rd. So probably in another week or so, that will be open again. You can go in and sign up so that you're signed up for the registry for 2018 if you haven't signed up for it before. If most registries, you'll pay a fee to utilize. That fee can vary anywhere from $300 to $600. To use the APMA registry, we're not charging members a fee, it's a member benefit. However, unless your EHR vendor is integrated, you're not going to be able to do your quality components.
So again, let me question, if I sign up now for the registry, I can still report 2017?
No. The question is, if I sign up now for the registry, can I report 2017? No, you needed to have signed up in the sign-up period that we had previously. This would be signing up to use the registry this year to report next year.
So I can still go through CMS and report for 2017?
Yes, sir. The question was, can I still go to CMS? Yes, you can. You can go through the CMS website. Do you have a question?
I did. You said if there were certain EMR companies that were ready for download. Do you have that available already?
The only one that's integrated so far is MediTouch. They're the only ones. We've reached out to and had conversations with, Diane's putting up, how many? 35 different EHR vendors that we have reached out to, worked with them, set them up to talk with the company that's built our registry that has to work with them to do the interface. So we've had a lot of conversations. We're trying to move that forward. It's really just, they have to do some work internally. They have to do a lot less work if they're 2015 certified, but if they're not 2015 certified, they may have some internal challenges to do the work, and they either don't want to take the time or the cost to do it. We don't charge them to integrate. This is all the cost to them in terms of production and software engineers and that type of thing. Oh, Monday, March 5th. I said the 3rd. It's the 5th we'll reopen the registry. And again, there's the website that you can go to. One of the other things I'm pleased to announce is that we have entered in to an agreement with a vendor for an analytic app at a severely discounted price for APMA members. So this analytic app is called MIPS Score. The normal price for this app is $4.99 per year per doctor, and the price that APMA members will be able to get it for is $349. What this analytic app does is, a lot of times if you're in a group and you're wondering, hey, should I report as a group? Should I report as an individual? This is an incredible app in that it looks at all the measures that you're reporting on. It will tell you how you're performing on that measure. It will tell you if there's other doctors in your practice, if they're all in there. It will tell you whether there's an advantage to report as an individual or as a group. It will also, say you're doing a measure and you look at your performance, and say your performance is 50% on that measure. Well, in some cases, if you improve your performance to, say, 75%, it's going to make a huge difference in your score on that measure. Because remember, I talked about the benchmarking on it. On other times, you could go from 50% to 85%, and it might not make a difference. This app will let you look to see, if I change my score performance from 50 to 80, what happens to my MIPS score overall, and it also calculates, based on Medicare data, and the best Medicare data it can get, what your incentive payment is going to be. If you're trying to maximize your MIPS incentive payment, if you're going to go full bore and do everything you can with MIPS, this app will easily get you much more than you invest in the app. An additional benefit, and this is the kind of just a byproduct of this app will also collect all your quality data and be able to transmit it to the APMA registry. So if your vendor has not integrated, for $349 you can get a great analytic app, and an additional bonus is this is a workaround on how you could get all 3 of your components into the APMA registry, because you'll still be able to attest for the improvement activities and the ACI, but this also allows you to do your quality data as well, and will easily pay for whatever you would have to invest in. The analytics is the reason to purchase the app. You don't have to get it. If you still want to just report the ones that you can report, the CPI and the improvement activities, you can do this. But this is a really good workaround that we've found, and it's really a great analytic tool. It's called MIPS Score. We're hoping to have it available for purchase within the first couple weeks of March so that you can start to use it. You can go to their website and see a demo on it. We're going to do some webinars so you can really get a feel for how it works. But it's a really good analytic tool, and it's a good workaround to now get all your quality data into the APMA registry. And that's all I have about registries. Be happy to answer questions.
If you've already reported for 2017, when and how will they inform you of what your incentive?
Say that again?
If you've already reported for 2017, when and how will they let you know what's your incentive?
They're never real firm with dates or things, but I would imagine it would probably be in the fall of this year. If you're going to get a penalty for 2018, unless, do you know when they're going to?
No,
Oh.
nobody knows.
Yeah, nobody knows. So probably in the fall of this year. But if you're going to get a penalty, you'll get a letter. Obviously, those that are getting penalized for 2019 will get a letter based on what they did in 2017. Any other questions? Any questions in general about MIPS, about the registry?
Just do all that work and wait 2 years.
Yes, you do all the work and wait 2 years. That's correct.
Bottom line.
That's the bottom line. And somebody asked earlier before the meeting started, is this just going to stay the same or are we going to stay with MIPS? Probably not. It will probably change in a couple of years. That's just, they continue to look for something and they haven't found it yet. Yes, sir?
What are they looking for?
They don't have enough money to pay for all the services that are provided, so they're trying to figure out a way to reduce the payments and cover everything. That's the bottom line. I mean, the pie's only so big, and so they come up with all these ideas based on payment for quality, payment for value of services provided, but truly they're not interested in that because we've gone to them and we've made proposals about things like a comprehensive diabetic foot exam. So we've said to them, why don't we do a pilot program? If you allowed because right now every patient with diabetes doesn't necessarily qualify to even be seen for an exam. I mean, as a new patient to you, they could, but beyond that, there aren't. And you got to jump through all these crazy hoops with class findings and things. So we said, well, what if every patient got a yearly visit that was covered, and then they got risk stratified? The risk stratification has already been set up by the American Diabetes Association working group. So you can look and see what's 0 risk, 1, 2, 3, high risk, and then you base your care based on their level of risk. If it's a 0 risk patient, you see them once a year. If it's a low risk patient, maybe you see them twice a year. High risk patients, they might be seen every 4 to 6 weeks. So you get away from this idea of having to fill out all these silly class findings, which obviously we know a certain percentage of patients don't have a dorsalis pedis pulse, but that's a class finding for a patient with diabetes. Doesn't make any sense. They're not at higher risk just because they have an anatomical variant, but this would actually make sense, and you wouldn't have to worry about it. You'd know you get paid for providing that care on a regular basis. They won't do that, and that would save them tons of money in the system because you'd prevent complications, you'd prevent ulcerations, you'd prevent hospitalizations and ultimately amputations. And those are the types of things that we continue to propose to make care better and really have value to the care. Like Dr. Lehrman said, there's no evidence so far that we did PQRS, we did meaningful use. Where's the evidence that that improved care? If it didn't improve care, they'd still be doing it and you'd be getting paid to do it, but it doesn't. So they're just searching to find a way to provide value and quality of care, but they haven't found it. Yes, sir.
Yeah, you might want to edit this question out. But I'd like to know, can you find out how much in their budget was spent in the store they bought the product in Colorado when they were formulating this whole?
Which?
Let's talk about what did the payroll
What were they
cost?
smoking? I want to know.
What did the payroll cost to create all that, is what he's saying?
Well, that, and what
How
they
much
got
did it
the
cost?
product at what store in Colorado, what they were smoking.
Yeah. Yeah, there's a lot of things that they did. I mean, if you think back to when they implemented electronic health records and what they wanted to do, remember the original proposal of electronic health records was everybody was going to be able to communicate with each other, so that patient would walk into your office and you'd be able to pull up their record. Oh yeah, you just saw your doctor for your management of your diabetes, your A1C was this, I see your most recent blood work, all of that. Didn't work. Why didn't it work? They found out that they let all these different EHR vendors pop up and none of them talk to each other. Why didn't they just develop one EHR and make it available to every Medicare provider? And that would have been a lot less than what they paid for meaningful use payments to providers, and providers would have been a lot happier. A lot more people would have engaged in using an EHR because you wouldn't have had any cost to you to do it. They would have provided the software for you.
They could have even charged for it and never done it.
Or they could have charged for it. So,
It would have been easier, and they'd have rather done that and pay them than it would be going through what they were.
yeah, so they've obviously missed the mark on a lot of things. Hopefully, some of this will improve. We continue to make suggestions to them. A lot of times they don't listen.
Are these doctors, what, any doctors helping so far?
No.
Are they doctors?
No, they're not doctors. How much time? Real quick anecdote. So, we're active in advocating. So when the 2016 presidential elections were up, we had some events. We weren't at the convention per se, but there were events that surround the convention. So I went out to Cleveland for one of the meetings, and they had the whole panel up there, and since we were one of the co-sponsors of it, we got to ask like one of the first questions. And that's one of the questions I asked. I said, why don't you involve the clinicians that are actually providing care when you start to make these changes in healthcare? And what I got was 5 people sitting there with a blank stare on their face. And finally, somebody stumbled out some answer that didn't make any sense. So it's like it doesn't even occur to them that the doctors, the clinicians, should be involved in this healthcare reform that they do. And that's really what you're dealing with. But there aren't. Typically, there aren't. They bring in economists, healthcare experts, and that type of thing to these.
So basically no one that knows anything.
Correct.